Well, good morning, ladies and gentlemen. I have nothing to disclose. Perhaps I have nothing useful to say. So now, if you look at the changing patterns of mortality in the world, in 1990 on here and 2020, you will see we made great progress in diseases of poverty, respiratory infections, perinatal, and in children, and they've come down. But depression has gone up, ischemic heart disease, cerebrovascular disease, and importantly, road traffic accidents have gone up, and it's the number 3 killer in the world. Now, this has increasingly led to a focus on what we call non-communicable diseases. And in a sense, I'm going to focus on cardiovascular disease only, although our work has extended now to all these domains. Now, if you look at the contribution of non-communicable disease and cardiovascular disease to the global mortality and burden, mortality is easy, burden takes into account how early the disease onset is. And if you look at that, total non-communicable diseases account for 59 or 60% of the global mortality, out of which 31% is cardiovascular disease. And if you look at the percent of this, 77% occurs in low and middle income countries, and 78% occurs of the cardiovascular disease occurs there. But if you move to burden, which takes into account the earliness of getting the condition, 85% of the burden of cardiovascular disease occurs in of non-communicable disease, and 86% occurs in low and middle income countries. So if you really want to solve the problems of the world, you need solutions that are applicable to the world. Now, the first thing was in around the mid-90s, we wanted to find out whether the risk factors for cardiovascular disease were similar or variable in different regions of the world. Now, as you may know, I'm originally from India, and there were data suggesting that Indians have more heart disease. And there was the theory that there were going to be new risk factors that was ethnic specific. So we wanted to look for that. The second one is whether the risk of an MI could be explained by known risk factors. For instance, every paper at that time in epidemiology said 50% of cardiovascular disease is explainable, 50% isn't. And in fact, Brownwall-Shattuck lecture published in the New England Journal opens with that line, and my grants opened with that line. Now, so these are the two questions we want to answer, and I can tell you we were wrong on both. The causes of MI are by and large similar in every ethnic group, and we could predict 90% of the cardiovascular disease. So we started a journey with $25,000, and we spread. Would you like to give the talk, sir? Would you like to give the talk? I really would appreciate silence because I get distracted. So 28,000 cases and controls from 52 countries. We started with $25,000, and you can see people just joined in. They didn't get very much money. They got $10 a case for getting us the data because they wanted the answer. And then when the results came out, we found that 9 simple risk factors explain 90% of the risk of cardiovascular disease, or this is called population attributable risk. What we do in calculating population attributable risk is you take the relative risk or odds ratio, plus you look at the prevalence of the condition. So if you have something that doubles the risk, but is very rare, the population attributable risk is small. But if something that doubles the risk, but is common, the population attributable risk would be much, much greater. And you'll see lipids are the number 1 cause of MI. Smoking is number 2. And I would say diabetes and hypertension are here. And these are probably underestimates because these were self-reports. Abdominal obesity, psychosocial factors, lack of fruits and vegetables, lack of exercise, alcohol, and or lack of moderate drinking of alcohol. Now, if you add up all of this is more than 90%. But what it means is if you take lipids, tobacco and hypertension, you can prevent 80% of cardiovascular disease, or or the attributable risk is well over 80%. That is huge. So we don't have to to deal with everything. The second point is that the risk associated with any risk factor was similar in the world. And you can see this is ApoB by ApoA1, which is much more sensitive than LDL, HDL. And you will see the risk is fourfold. But in Western Europe, Central Europe, Middle East, Africa, South Asia, China, Hong Kong, every part of the world, the risk was the same. So this was the universality of risk factors. If you take smoking, again, the risk is increased 2.5-fold, and it's more or less the same in every part of the world. There were only two risk factors that behaved differently in different parts of the world. One was diet, and diets vary enormously in different parts of the world. And even a fruit is not a fruit. A fruit in Canada or the US is not a fruit in India. How it's cooked varies, how it's grown varied, what insecticides and pesticides are varies. And when you eat something, you don't eat something else. It's called displacement. So diet, it's not surprising you're going to get different answers in different parts of the world. And in fact, our subsequent studies are confirming that, and we are writing that up. The other one that seems to vary in the world is alcohol. I think the patterns of alcohol drinking are different in Western countries where small amounts are drunk regularly, usually with meals, and very rarely do people go into binge drinking. It is there, but it's rare. Whereas in other countries like India, people drink to get drunk. And it's very, very different. And what is alcohol varies. In the West, they're highly controlled compounds or products, whereas in countries like India, it's a lot of country hooch. So I think alcohol and diet is variable. Then after doing into heart, we turned our attention to stroke. Stroke is much more complicated. First, you have ischemic strokes and hemorrhagic stroke. Ischemic strokes, you have many different kinds of strokes, like lacunar, atherothrombotic, cardioembolic, and a bunch you don't really know the cause. And even hemorrhagic strokes, you have intracerebral hemorrhage and subarachnoid hemorrhage. So to do a large study, you need imaging in everybody. So our big challenge was how was we going to get neuroimaging early after stroke, even in deepest, darkest Africa. But we managed, and we've just finished a study of 25,000 people, half cases, half controls, and the full report is in press, should come out in the next 3 or 4 weeks in the Lancet. But these are data from our pilot study of 6,000 people, and basically it showed 90% of all strokes and ischemic strokes and intracerebral hemorrhages could be explained by 5 simple risk factors and 95% by 10 risk factors. And all the risk factors were the same except for atrial fibrillation, which obviously is a risk factor for ischemic strokes, but not for MI. So after having shown that these risk factors are associated, I'm not saying cause and effect, associated with the majority of risk globally, we could go 2 ways. We could intervene to reduce them, or we could try to understand why do these risk factors occur. And that's been the journey we've been through in the last 12 years, and we have some data on both. So the first is we set up a study called PURE. It stands for Prospective Urban Rural Epidemiological Study. Initially, it was in 663 communities in 22 countries from 5 continents. And you'll see North and South America, Africa, Middle East, Europe, China, India, Southeast Asia. We've now expanded it to 30 countries. Russia has joined, Central Asia with Kazakhstan, Kyrgyzstan, and we've expanded to Northern Africa with Sudan and hopefully soon with Tunisia. And overall, right now we have 190,000 people in the study. We're trying to go to 250,000. So initially when we started, we wanted about 150,000 adults from many countries, low, middle, and high income, half urban, half rural populations. And the reason for this is we wanted to spread the environment. So by having low, middle, and high income countries, you'd spread it one way. Within each, spreading it out by urban and rural, you'll spread it out another way. And we were very much interested in the societal influences, socioeconomic factors, tobacco and other health policies. So even if you have laws on tobacco, are they being implemented? So laws on the books versus laws on the street. Relative food prices. We can say eat 5 servings of vegetables and fruits every day, but are they available? Are they affordable? And I won't show you data on it, but we have a paper in the Lancet, and I'll tell you about it in a minute. And then we wanted to look at the built environment. Is the New York environment, where you don't see any greenery, with lots of traffic, more conducive to health than one, say, 50 kilometers away out in rural New Jersey? I don't know. And indoor and outdoor pollution. And there's a lot of claims that outdoor pollution is the biggest cause of cardiovascular disease. Maybe it is, maybe it isn't. So we had to look at that. Then we looked at these factors and how they affected behaviors, interacting with genes for risk factors, and then a range of chronic diseases, but I'm only going to focus on cardiovascular disease. Now, one of the first questions we asked is, why do the majority of cardiovascular disease occur in poor countries? Is it because the risk factors are higher? Is it because cardiovascular disease incidence is higher? Is it because case fatality rates are higher? Or is it simply because the majority of the world lives in low and middle income countries? So the first thing we did was look at risk factor, and there's an integrated risk score. If you use a Framingham risk score, you get exactly the same result. And you will see actually the high-income countries had more risk factors, middle-income countries intermediate, and low-income countries about a third lower risk factors. So you'd expect a third higher cardiovascular disease event rates if risk factors were the only things, and much lower rates here. However, we found something quite different, a paradox. The paradox was that major cardiovascular disease events, which is CV death, stroke, MI, and heart failure, was actually 50% higher or 60% higher in poor countries compared to the rich countries, and despite the fact that the risk factors were lower here. And the reason for that is in the rich countries, we intervened earlier. So non-major cardiovascular disease is things like angina, interventions, all of that, and therefore we prevented it from progressing. Second was we looked after our people better. That's why fatal cardiovascular disease is 6-fold higher in the poorer countries, 3-fold higher in the middle-income countries compared to the rich countries, and total mortality is different. This actually is an important message because so far, global efforts at cardiovascular disease control by WHO has focused on risk factors or public health measures. They are important. Having said that, what we are seeing is health systems and health cares matter. And, I don't know whether these fancy stents do anything, but I can tell you simple aspirin or statins do a whole lot of things. So now, you don't want to hear that message, and if you want to invite me back, I'll give you a reason why those 10 advances aren't that big advances. But but you'll never invite me to give that talk, and Samin will never invite me to give that talk. Anyway, coming back to this, if you look at mortality after MI, stroke, heart failure, major cardiovascular disease, you'll see these steep event rates. So that what this is telling you is healthcare matters. The challenge for us, all of us collectively, is which aspect of healthcare really matters? And in matters, it means death, MI, heart attacks, strokes, important events. And do they matter in an affordable way? Now, we looked at simple things, simple secondary prevention measures, antiplatelet agents, beta blockers, ACE inhibitors, or statins. And you will see even in rich countries like Canada and Sweden, which is what our high-income countries were, where we have universal health coverage, okay? You'll see, even 5 years after an MI, 60% are only getting aspirin. And then when you go to upper middle-income countries, low middle-income countries, and low-income countries, you'll see it's 5 to 10%, say in rural India, rural Africa. Beta blockers, the same patterns. ACE inhibitors, the same patterns. Statins, even more marked. Look at this. In Africa and in Asia, South Asia, that is India, Pakistan, Bangladesh, large parts of Africa, less than 5% get a statin after an MI. So these are the priorities. If you look at hypertension control, and that's just the Prevalence is more or less the same, although hypertension is less common in low-income countries compared to high, upper middle, and low middle income countries. You will see that even in the rich countries, and this is Canada, and Canada's hypertension control is better than the US control rate, only 50% are aware. Now, once you're aware, most are treated, but even when you treat, only 19% are controlled. And control here is blood pressure less than 140 by 90, not the aggressive sprint targets. So even in this city, your hypertension control is poor. So get that done right first before you do anything else. And low-income countries, you'll see, and low-middle-income countries, control is only 10 to 30%. So these are the low-hanging fruits that if we tackle will make a huge difference to cardiovascular disease globally. Now, why is it that these drugs are not used commonly? And the reason for that is, first, lack of availability. In rich countries, they're available. So no wonder they use more than in poor countries. But that still doesn't explain why in Canada, Sweden, US, and other countries, it is only 50%. If you look at upper middle income countries, it's lower, urban and rural. Low middle income countries and low income countries, excluding India, 36% availability of the 4 secondary prevention medication compared to none in the rural areas. And if you look at India, though, because of the large generic companies, you will see actually availability is the same as in rich countries, but there is going to be an important paradox. So why is it India has low rates of use and Canada has high rates of use when they have the same availability? The answer is in the next slide: affordability. And you will see in rich countries, even if we had to pay out of our pocket, these 4 drugs are less than about 2% of a month's salary of that person. Or not salary, this is after taking into account costs of food and costs of rent, etc. In upper middle income countries, it's somewhere from about 3% to about 10%. In low middle income countries, about the same. Low income countries, excluding India, these 4 drugs in urban areas cost about 15%. And in rural areas, it costs about 50%. And look at India. Despite the wide availability, you will see it's about 15% of the income versus 65, 70% of the income. Now, this is horrible. Simple drugs for one person's condition, for one disease. Now, several of them will need additional antihypertensives or medications for diabetes or for their arthritis. That's not taken into account. And we're not taking into account doctors' fees, cost in traveling to see a doctor, and time off work. So in reality, essential drugs are unaffordable for the majority of the world, and in rich countries, essential drugs are available and affordable, but yet they're not used fully. So I'll skip that. So now when you look at the availability, and clearly if the drug is not available, the rates of use are 90% lower. If they're available but are unaffordable, you will see it's about 83% lower. So these are 2 fundamental factors we have to tackle to improve things in the developing world or in poor resource settings in this country. For instance, in Harlem, affordability becomes an issue. So those are the things that you have to tackle first, and then worry about the fancy-dancy things that you talk about the rest of this meeting. Now, a few years ago, there was a proposal that if you combine the 4 essential drugs into one pill, you can improve access, you can improve affordability, but most importantly, you might reduce cardiovascular disease by 80%. I have to emphasize this is too good to be true, but what if it's half that? That is still huge. Imagine 40% reduction in mortality, premature mortality, by 4 simple drugs in people with vascular disease, costing less than 25 cents a day. That is enormous. But again, you need proof. So we set about formulating a polypill with aspirin, simvastatin, ramipril, atenolol, and hydrochlorothiazide with an Indian company. And we did 2 phase 2 trials, total of about 3,000 people, and we estimated, based on the lowering of LDL blood pressure and impact on LDL, on platelet function, 70 to 80% reduction in CHD and stroke. But in real life, people are not adherent, and in real life there may be other competing risks, so you really have to do the right trials. So the first trial we did was what we called a trial on the Polypill concept. We weren't brave enough to go into a large trial with 3 blood pressure lowering drugs at full doses, plus a statin plus aspirin. So instead, what we did was we went with an intermediate risk primary prevention population, because you can't do a placebo-controlled trial in secondary prevention. That would be unethical to give placebo. And we went with a low dose of candesartan and hydrochlorothiazide, 2 drugs, not 3 drugs, and with a moderate dose of a potent statin, 10 milligrams. So the design of the trial was what we call a factorial design, something I love. We have 14,700 people entering the study. 87% got randomized. Half of them got randomized to the blood pressure lowering versus placebo, and the half got re-randomized to statin versus placebo. So we were able to address 2 questions in one. In fact, we were able to address 3 questions in one design, because we have the combination of statin plus blood pressure lowering versus double placebo. And that is the concept of the polypill. It's still not a polypill. So the neat thing is we had people that looked more or less average. I mean, we had to use a lower age cutoff to get people to have some appreciable risk. So it was age over 55 in men and over 60 in women. Half were women. You'll see blood pressure is not really wildly elevated, sort of, you'd say, borderline hypertension. LDL is about average. Obesity, abdominal obesity, was the commonest cause. No enrichment with diabetes, slight renal dysfunction. But the important thing is down here. This is the first trial with ethnicity representativeness across the world, more or less. White Caucasians, 20%, 30%. Latin Americans, 30% Chinese, 20% South Asians. These 2 are the biggest studies of statins, and this one, the 20%, is both statins and blood pressure in a South Asian population. A small proportion with Africans. We wanted more, but we couldn't get more. This is the difference in blood pressure, about a 6 millimeter reduction in blood pressure systolic, 3 millimeters, and it's pretty constant throughout. And unfortunately, theory and practice diverged. We did not see a clear reduction in cardiovascular event rates by the blood pressure lowering, although this could well be that with time there may be a difference. So we are conducting a 5-year extended follow-up. But we had something very interesting. The first is we pre-specified, there's absolutely pre-specified in the protocol, that we would divide people into thirds of blood pressure, and then we would look at the effects. And our hypothesis was the higher the blood pressure, the greater the benefit. And you will all agree that's a reasonable physiological hypothesis. So in the people with the highest blood pressure, the mean cutoff was about 143. And once you take regression dilution into account, that's really about in the high 130s. The second thing is the mean blood pressure is 154 here, 138 there, 122 here. Surprisingly, the reduction in blood pressure was about the same. And now we understand the reason for that is there was more crossovers here from the placebo group. 32% received 1 added medication compared to about only 10% in the active group, whereas it was much lower here. So that, in a sense, would attenuate the benefits. And you'll see blood pressure nicely stratified people into high risk, intermediate risk, and low risk. And this is the point, that the benefits were greatest in those with the highest blood pressure, neutral in those intermediate blood pressure, and tendency towards harm in the lowest blood pressure. And this p-value is an interaction statistic comparing this versus this versus this, and that's highly significant. We saw that in every other endpoint we looked at except for stroke. Stroke seems to benefit even at lower blood pressure. So about 4 different composites, they all showed the same. Then turning to the cholesterol lowering arm, you will see LDL is reduced by about 1 millimole or about 35 milligrams per deciliter. That's about 27% reduction. ApoB was reduced and CRP was reduced. And this is unlike the Jupiter trial. We included everybody irrespective of CRP. And I can just tell you the results were identical whether your CRP was elevated or not. So it's good news. You don't have to measure CRP. And these are the results, much more striking than the blood pressure lowering, a 25% risk reduction. And if you look at it, very little effect at 1 year. By 3 years, the curves diverge, and they diverge widely. And in reality, when you use a statin lifelong, you're going to see an effect that is closer to this rather than this lag phase. And that's not surprising. Atherosclerosis develops over several decades. It can't be reversed in 1 or 2 years. Now, a second point is to think that a 7-year trial or a 6-year trial is really a 3-year trial. And why do I say that? You see, people start to have the events from time 0 all the way there. So the mean time to intervention is in the midpoint. It's about 3.5 years. So if in 3.5 years, we're able to reduce the risk by a quarter, likelihood is by 10 years, we will reduce the risk by about a third. And this is modeling, taking genetic epidemiology, classic epidemiology and trials. You know, if it say genetic epidemiology is lifelong differences in LDL, what do you get? You get a 50% reduction for a 1%, 1 millimole, that's about a 40 milligrams per deciliter difference in LDL. If you take classic epidemiology, you get a 35% risk reduction. If you take trials, you get a 25% reduction. So trials are underestimating the effects. And the amazing thing was as expected, we had a reduction in coronary heart disease. But this is the interesting thing. Strokes were reduced. And strokes were reduced more with statins than they were reduced with blood pressure lowering. This is a new finding. Now, what about combination therapy? And this is looking at the 3,200 people with double active versus the 3,200 with placebo. And the results were even more striking. At 28% reduction, you'll see the curves diverge very markedly. But when you look at coronary heart disease, nearly a 40% risk reduction. These are important risk reductions. These are huge. And strokes, there's a 45% risk reduction. This was the big surprise in the study, the impact on stroke. And remember, globally, the number of strokes in the world is only a little less than the number of MIs. But we need to look at these data by hypertension. Now, overall, you will see combination gave you a 28% effect. Rosuvastatin alone gave you a 26% effect, and blood pressure lowering very little, but that's hiding something. If you look at the highest third of blood pressure, you will see both statin and blood pressure lowering contributed. So your benefits were large, 40%. And if you exclude the first 2 years, it's nearly 50%. That's a big effect. In those with the lower 2/3 of blood pressure, you will see statins alone provided substantial benefit. There was certainly no benefit with blood pressure lowering, maybe even a tendency to harm. So there's a very nice message in the study. In people who are hypertensive, use both statins and blood pressure lowering. Nobody will argue with that. And in those who are not hypertensive, just give a statin. Now, this is important because the approach in the US has been to drive the blood pressure lower and lower. That may work, but it has huge side effects, as in the SPRINT trial. There was an increased hospitalization for acute renal injury. What this approach is telling you is rather than driving it all the way down, attack multiple risk factors. That is a kinder, gentler way, and you'll get a bigger benefit, and you need very little monitoring. In this trial, we had very little safety monitoring. So I think the Polypill can transform primary and secondary prevention. We're doing another large trial called TIPS-3, funded by the Wellcome Trust, that has just got 3,500 people, where we are taking 3 blood pressure lowering drugs at full doses, statins versus placebo, and aspirins randomized as a factorial, and that result should come out in 2 or 3 years. Anyway, and we're trying to get 5,000, but we at least need 4,000. We'll hit 4,000 in about 4 months. Now, anyway, so the Polypill can be simple. It is effective in high-risk people like hypertension, diabetes, and secondary prevention. I would not advocate the Polypill for everybody. And in fact, in primary prevention, average risk people take a statin if you need it. It's safer and more effective than aspirin. And it can potentially prevent not 80%, but about half the events, 40 to 50%, and perhaps more in secondary prevention because the non-blood pressure effects of ACE inhibitors and beta blockers kick in. Now, we know tobacco control is important, and we know physical activity is important. And note, I haven't said much about diet because I think the dietary area is quite confusing. But having said that, I'm sure there's some protective effect of diet. So if you add it all together, it's 75 to 80% risk reduction in cardiovascular disease and premature mortality is possible, highly likely. And if that is so, the potential impact of this combined strategy globally is the avoidance of 5 to 10 million cardiovascular disease events globally every year. And this will be cost saving. It won't, because the reductions in events will pay for itself and the increase in productivity will pay for itself. So we are on the verge of a revolution in cardiovascular disease. About 90 years ago, this hospital and most hospitals in the US were full of people on ventilators being treated for polio. You know, kids were on what is called iron lungs. Those were your first crude ventilators. You don't see a single one around. You know why? Because we've eliminated polio from the Western Hemisphere, and we're on the verge of eliminating polio from the world. Why can't the same thing happen to cardiovascular disease, at least premature cardiovascular disease? And by that I mean under the age of 70 within a generation, so that our grandchildren would not know what getting a heart attack is in middle age. I think it is possible, and I think that's where our focus should be. Thank you very much. These are all the wonderful people working with me.